Hello, everyone. I am Dr. Anna Pellat, and I'm a French digestive oncologist working in Hôpital Cochin, Paris, France. And I am the first author of a paper that was published in gastrointestinal endoscopy. And the paper is the following: ability of computed tomography and endoscopic ultrasound to predict the PTNM staging of resected ampullary carcinomas. And this was an analysis of a French prospective cohort that was led by the Fédération Française de Cancérologie Digestive. So, to put some context, you all know that ampullary carcinomas are rare digestive tumors, and that the pre-therapeutic evaluation of the localized forms is very important as it can influence the therapeutic strategy if you're going to discuss endoscopic resection or even sometimes a type of surgery. Currently, the European guidelines recommend the performance of an endoscopic ultrasound to evaluate TNN stages, but also vascular and local extension, a computed tomography to assess lymph nodes and metastasis, and sometimes MRI or PET-FDG. Why did we feel a need to do our study? We felt that there was currently limited data actually in the literature, especially on the performance of both endoscopic ultrasound and computed tomography. The available meta-analysis are based on small retrospective data sets. It is said that the sensitivity for PT evaluation by endoscopic ultrasound is 70%, but with heterogeneous numbers. And maybe also that the endoscopic ultrasound is better than the computed tomography for both T and N staging. Our objective in the study was to evaluate the ability of both computed tomography and endoscopic ultrasound to predict PTN stage of localized ampullary carcinomas. So we performed a multicentric prospective national French cohort that took place in 48 French centers and including, of course, Hôpital Cochin. And we included all patients that had an ampullary carcinoma that was resected with a curative intent, and this was in a real-world setting. So we had 389 patients analyzed. And as you can see, the majority were operated on with a different type of pancreatic surgeries, 370, and sometimes ampulectomies by surgery or endoscopy. So the first main result for evaluation of PT stage by endoscopic ultrasound, 143 patients were accessible for this information. First, you can see on the first table at the top is that the majority of patients were either PT2 or PT3. And then on the table at the bottom, you can see for the prediction of PT1 that the negative predictive value was 93%, pretty high. For PN, still with the endoscopic ultrasound, 160 patients accessible. On the first table, you can see that's pretty much half and half in terms of non-invasion. And on the second table at the bottom, you can see that we had a good negative predictive value of 75% to be sure that we were PN0, so no nod invasion. What about computed tomography? So this time you only looked at the end staging, as T is not really relevant with this modality. 185 patients were accessible, and the first information to note is that 42% of the patients were considered NX, meaning non-accessible by CT, and that's different than missing data. On the first table, again, for pathology, about half and half, a little more of PN0 in this subgroup, I mean, in this population and what it represents. And on the second table, high sensitivity to predict PN0 and also a better or higher negative predictive value also to be sure that we are without node invasion. And when you combine both modalities by taking the worst result assessed by either one of these modalities for PN only, 227 patients that had the data available, we did not increase the negative predictive value of prediction of PN0. And also the agreement between the two modalities was low with a kappa coefficient of 0.3. So a little bit to discuss. The strengths of our study were that it was a large cohort perspective with the quality control of pathology data, and the limits, obviously, missing data. The fact that it was multicentric actually led to the fact that there was no standardization of reports and different expertise. There was also a long time range for inclusion. Of course, differences, like I just said, of expertise in different centers and also the different type of endoscopes used. What does our study add to existing knowledge? So we found that there was low performance for both CT and endoscopic ultrasound to correctly assess PTN stage in this setting. We found lower performance for prediction of PT with the endoscopic ultrasound compared to the data in the literature, and also underestimation of about 39% of patients that were considered wrongly T1, T2 when they were actually PT3, T4. But there was a good negative predictive value for PT1 prediction. Like I said, computed tomography is not a great modality to assess NOD because it was often considered non-accessible, not invasion, sorry. And both endoscopic ultrasound and CT do seem reliable for assessment of PN0 with good negative predictive values when it's possible, but there's still a high rate of false negatives with patients that were actually PN plus and assessed PN0. What to discuss? The prediction of PT1 and endoscopic ultrasound is important, especially when you're trying to discuss endoscopic resection. So you need to know if it's actually really T1 and not T2, T3, 4. It's less important if you misclassify between T2 and T3, 4 because it has less therapeutic impact and you're going to operate on the patient. Um, Other modalities, such as regular endoscopy, can also help you to characterize the lesion. And of course, what I also meant here is that if you wrongly resect by endoscopy a patient and it's more than a PT1, you can always go back to surgery or as a second step. There are some limitations to endoscopic ultrasound because it's currently very hard to distinguish between T1A and T1B, which may be important to know if you're actually truly curative with your endoscopic resection, but it's currently unknown what the true not involvement is in these two situations. Regarding PN, maybe it's not that important to have a pre-therapeutic evaluation of that parameter because even though it could be useful if you want to discuss in clinical trials, maybe a neoadjuvant treatment or sometimes the endoscopic resection, of course, assessing end stage before surgery may not be greatly important as it will not impact your type of surgery or in very rare situations. What should come next following our study? We still need standardized reporting for both endoscopic ultrasound and computed tomography reports over different centers, a better definition of what a pathological nod is in endoscopic ultrasound. We might also need some data on the role of MRI and maybe PET-FDG in the setting, or maybe for a better definition of non-involvement. And we also need to know how many or what the true value of non-involvement is for PT1A and PT1B tumors to know if endoscopic resection is truly enough for these patients. Thank you very much for your attention. And of course, do not hesitate to write on my email if you have any questions.